Welcome to this clinical synthesis briefing on neonatal cerebral autoregulation. When we look at the adult or older child's autoregulatory curve, we see a broad, forgiving plateau. Within a wide range of central perfusion pressure, or CPP, the adult cerebral vasculature actively constricts or dilates to keep cerebral blood flow perfectly stable. In the preterm infant, particularly during the critical first 72 hours of transitional life, that safe plateau virtually disappears. Preterm infants operate within a razor-thin safe window. Small fluctuations in systemic pressure can rapidly push the infant out of the autoregulatory zone into a dangerous, pressure-passive state where perfusion blindly follows pressure. To understand how this balance breaks down, let's review the core equation. Central perfusion pressure is the gradient between inflow pressure, represented by mean arterial blood pressure, and outflow resistance, driven by intracranial pressure or central venous pressure. Autoregulation is the active muscular work of the resistance vessels accommodating these shifts. This system is bounded by two distinct thresholds, the lower limit of autoregulation. Here, cerebral vessels are maximally dilated. If CPP drops any further, blood flow plummets, inducing ischemia. The upper limit of autoregulation. Here, vessels are maximally constricted. Any further pressure spike causes breakthrough hyperperfusion, exposing fragile capillary beds to reperfusion injury and hemorrhage. In a busy NICU, everyday interventions and physiological shifts constantly push infants toward these limits. Factors that drive cerebral blood flow upward include systemic hypertension, inotrope escalations, hypercapnia, fluid overload, or unmanaged pain and agitation. Conversely, drops in cerebral blood flow are driven by systemic hypertension, hypocarbia from hyperventilation, high mean airway pressure on mechanical ventilation, high intracranial pressure, or oversedation. Crucially, the autoregulatory curve itself is not static. It shifts in response to clinical conditions. First, intracranial pressure. Conditions like posthemorrhagic ventricular dilation increase ICP, creating a mechanical barrier to incoming blood flow. This shifts the lower limit of autoregulation upward. The infant now requires a higher systemic mean arterial pressure just to maintain baseline brain perfusion. Second, carbon dioxide levels. Hypocapnia below 35 mm of mercury causes profound cerebral vasoconstriction, drastically increasing the risk of ischemic brain injury visible on MRI. Conversely, severe hypercapnia causes marked vasodilation, shifting the lower limit of autoregulation to the right. Maintain carbon dioxide levels at or above 35 mm of mercury. Even a 5 mm drop significantly impacts regional cerebral oxygen saturation. Third, therapeutic hypothermia. During the first 24 hours of cooling, hypothermia lowers the lower limit of autoregulation. However, by days 2 and 3, the curve shifts back toward baseline. The highest period of vulnerability occurs during rewarming. Deviations below optimal blood pressure targets during rewarming strongly correlate with severe 2-year motor and cognitive deficits. During the transitional period, a hemodynamically significant patent ductus arteriosus presents a severe challenge. As pulmonary vascular resistance drops after birth, a persistent left-to-right ductal shunt can steal up to 80% of cardiac output away from systemic and cerebral circulation. This acute drop in inflow pressure forces the premature brain directly into a pressure-passive state, sharply increasing the incidence of germinal matrix intraventricular hemorrhage within the first 72 hours. How do we monitor this dynamic vulnerability at the bedside? Point-of-care ultrasound gives us the resistive index. Assessing the anterior or middle cerebral artery, a low resistive index tells us that vascular resistance has collapsed. The vessels are maximally dilated to salvage flow, signaling that the infant has breached the lower limit of autoregulation. However, intermittent ultrasound snapshots cannot track continuous dynamic risk. This is where continuous near-infrared spectroscopy, or NIRS, comes in. By analyzing the correlation between mean arterial pressure and cerebral blood volume, we derive the hemoglobin volume index. When autoregulation is intact, MAP and NIRS display a negative correlation. As blood pressure drops, healthy vessels dilate, increasing local cerebral blood volume. When autoregulation is impaired, MAP and NIRS display a positive correlation. As pressure falls, cerebral volume drops in tandem. The brain is entirely pressure passive. Looking ahead, emerging research tools like diffuse optical spectroscopy and diffuse correlation spectroscopy move beyond static oxygenation by measuring light scatter from moving red blood cells, providing continuous, direct measurement of cerebral blood flow during high-risk procedures like extracorporeal life support. This brings us to an essential paradigm shift in modern neonatology. We must move away from management based solely on static, population-based blood pressure charts. By combining real-time data, continuous NIRS, Doppler indices, and AEEG, with dynamic clinical modifiers like CO2, temperature, and ventilation settings, we can identify the specific, shifting optimal map for an individual infant in real time. To summarize our clinical takeaways, the window is razor thin. Preterm infants operate on a knife edge during the first 72 hours. Meticulously manage modifiers. Avoid hypocapnia below 35 mm of mercury, anticipate elevated ICP, and maintain tight pressure control during hypothermia rewarming. Monitor the trend, not just the number. Static blood pressure values are blind to passivity. Watch for positive correlations between pressure and NIRS indices to catch loss of autoregulation before irreversible ischemic or hemorrhagic injury occurs. Thank you.